Hey, I'd like to welcome everyone to today's unveiling of CADTH's 2024 watch list of the top technologies and issues related to the care for children and youth with medical complexity. My name is Sudha Cuddy. I'm the Executive Vice President of Evidence Products and Services at CADTH, and I have the pleasure of being today's moderator. Je m'appelle Sudha Cuddy, je suis la vice-présidente directrice aux données probants, produits et services de la CMTS et je suis ravie d'être l'animatrice aujourd'hui. I'd like to begin by acknowledging that I'm speaking to you today from the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, the Wendat peoples, and I'd like to acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. So a few housekeeping items to go over. During the moderated portion of today's webinar, we'd like to have time to take several questions from the audience. To pose a question, please submit your questions at any time by using the question and answer tab in the Zoom control bar. The watch list report can now be found on our website. And after this event, we'll send an email to all registrants with a link to the report and the recording. In terms of our disclosures, here is CADTH's standard disclosure slide to highlight that we are funded by the federal, provincial, and territorial ministries of health, with the exception of Quebec, and that we receive application fees from the pharmaceutical industry for reimbursement reviews. So let's get started. Here is today's agenda. I'm going to begin by introducing our panelists and then provide a brief introduction to the 2024 watch list, including how it was developed and the 10 items on the list. After this, we will head into a discussion about the items on the list and what it could mean for health systems across Canada. So today, I'm thrilled to be joined by an amazing and diverse panel of experts. Laura Williams, who I've had the distinct pleasure of working with in the past, has worked in the field of patient engagement and experience for the past 15 years, including a focus on children and youth with medical complexity. She is currently the Senior Director of Patient Experience at the University Health Network. Laura is also the proud mom to 2 kids, Connor and Bryson. Bryson is a 16-year-old and has a rare genetic condition called GRIN1, which causes physical and intellectual disabilities. This has motivated Laura to pursue a doctorate in rehabilitation and health leadership at Queen's University with a focus on transitions for youth with intellectual disabilities. Next is Dr. Kyle Millar. Dr. Millar completed his pediatric residency at the Pediatric Complex Care Fellowship and a Master's of Science at the University of Manitoba. He has worked in rehabilitation and complex care at the University of Manitoba since graduating, with most of his time dedicated to complex care and complex feeding, and he has been the section head since 2022. And last but not least is Nadine Gall. Nadine has a Master of Science in Epidemiology with diverse experience in designing innovative models of care and strategies for children and families with complex and medical and psychosocial needs. Nadine oversees a range of acute care services at the Alberta Children's Hospital, including complex care programming for inpatient and outpatient services, as well as community-based programming to support care closer to home. Nadine has a long-standing interest in health ethics and trauma-informed care. And here are everyone's disclosures. Okay, so to our main event. So for those who may not be familiar with our watch list, it's an annual report that forecasts 5 emerging technologies and 5 issues that have the potential to transform health systems over the next 5 years. For this list, we define technologies as medical devices, diagnostic tests, clinical interventions, and models of care. And the issues under considerations really had to be ones that cross-cut the broader scope of care for this population and could impact how such care and related technologies are developed and adopted in Canada's health system. Unlike others in the medical devices space, CADTH's list is really meant to be impartial and intended to inform health system planning in Canada. While previous iterations of the watch list really highlighted top technologies that spanned a wide range of clinical areas, in 2023, we really started focusing on technologies related to a single theme. Last year's theme was precision medicine, also referred to as personalized medicine. And this year, we are pleased to have a theme with a focus on the care for children and youth with medical complexity. Truly a diverse and equity-deserving group who often live with chronic conditions and functional limitations that lead to substantial healthcare needs. To provide insight into the experiences of caring for a child living with a complex medical condition, the watch list opens with a vignette written by Laura Williams, who shares her journey caring for her son who was born with a rare genetic disorder. In this vignette, Laura describes the challenges of navigating the healthcare system without a clear guide, difficulties in accessing pediatric-specific services, and uncertainties when looking ahead to the transition to adult care. She also describes how children and youth with medical complexity require consistent and comprehensive support, including funded technologies that don't just offer care, but enhance their quality of life. I'd truly like to thank Laura and her family for providing their insights and experiences on their journey caring for a youth living with a complex medical condition, and really invite everyone to read the vignette that opens the watch list. So just a little bit about our development process. CADTH's watch list is quite a unique example of co-creation by a diverse range of contributors. An advisory group of external experts guided the overall direction of our work, including providing input on a short list of approximately 20 items identified by CADTH from the published literature and industry news. The final 10 items were selected using a modified James Lind Alliance approach to facilitate consensus in a priority setting session that was held in November 2023. This session involved caregivers, healthcare providers, researchers, policymakers, and industry representatives. I think I'll perhaps note as well, while the watch list items are numbered, they're not ranked in any order of importance. So the 5th item, for example, is no more or less important than the first. And so now on to the items themselves. I will briefly go through the 5 technologies and 5 issues, and then pass it over to our expert panels for a more robust discussion, so we can discuss in detail both the value and the disruption or complexities that these technologies and issues bring to our health system. So firstly, new models of care. Family caregivers of children and youth with medical complexity often have the significant task of coordinating their child's many care activities and finding the necessary resources to do so. New models of care seek to improve how health services are organized and delivered for this population, and often include enhanced care coordination, active co-management across all care providers, and assistance during transitions of care, like from pediatric to adult care. Number 2, technologies and systems that improve communication. The statement "communication is key" could not be truer when it comes to caring for children and youth with medical complexity, who, as I've noted, often require care from multiple healthcare providers in multiple settings. Technologies and systems that improve communication between providers and families have the potential to save time, reduce errors, and lessen the workload for family caregivers. Thirdly, genetic testing. The rapid emergence of technologies that enable more personalized medicine show no signs of slowing down. Growing interest in genetic tests like the whole genome sequencing and pharmacogenomic testing have the potential to provide even more information and lead to faster diagnosis and greater patient care. Number 4, monitoring devices that improve patient experience. Children and youth with medical complexity must endure many medical tests, some of which can be stressful and painful. New technologies could replace uncomfortable procedures with something less painful or entirely painless. They may also allow patients to be monitored closer to home. Number 5, mental health support for caregivers. On average, children and youth with medical complexity in Canada receive 44 hours per week of informal care from family and friends, which often requires a family caregiver to give up paid employment. This, in combination with the high expenses of caring for their child, can negatively impact the caregiver's mental health. New and emerging supports for caregivers aim to improve their mental well-being, which can result in better health outcomes and quality of life for both caregivers and their children. We now move to the top 5 cross-cutting issues that warrant attention if health systems are to realize the full potential of these technological advancements. The need for increased interoperability. As we know, the health information of people across Canada is increasingly being stored in digital systems like EHRs and mobile apps. However, these systems often vary by provider, setting, and region, with limited ability to share and exchange information. Improving the ability for different digital systems to communicate with each other would allow for timelier access to vital patient data, reduce burden on caregivers to manage and communicate large amounts of health information, and reduce the risk of information gaps. Number 2, barriers to access and use. New technologies are only beneficial if they are accessible to those who need them the most. To address disparities in access and use, health systems must explore strategies to remove barriers and ensure equitable access to resources. Thirdly, evolving practice for healthcare professionals. The field of complex care is evolving, bringing with it new roles and responsibilities for healthcare professionals, as well as additional demands on an already strained healthcare system. Health systems must consider the resources and time required to prepare complex healthcare providers for an expanded role. The need for strategies to improve sustainability. New health technologies for children and youth with medical complexity are often introduced through pilot projects. And when these pilot projects end, patients and caregivers and providers can be left asking what's next. Implementing strategies to ensure the sustainability of new technologies that show promise help ensure that they are implemented as a standard of care and made available to more people who could benefit from them. And last but not least, the need for additional support for caregivers. Supporting children and youth with medical complexity must happen within the context of the family. In other words, the carer should be cared for as well. Health systems should consider the types of supports and services caregivers may need: psychosocial, physical, financial, and mental health support, so they can provide better care for their children and themselves. And that's the 2024 watch list. I'm now delighted to move into what I hope you will find will be an engaging discussion with our expert panelists. You may submit your questions by clicking on the Q&A tab in the Zoom control bar. And I'm going to now start by asking each of our panelists, and maybe Dr. Millar, I'll start with you. Which item on this list resonates the most with you and why? And how might this really impact your everyday?
Well, thank you for inviting me. What stood out the most to me, there's a lot of great stuff in this report, by the way, but what really stood out to me was the technology number 1, new models of care. It's hard to talk about why a new model of care is necessary without talking about the current system. So I want to start by saying the medical system is full of dedicated people. They're doing their best for these kids and families, but they're really working in an existing system that was designed before the real emergence of these children. So our current system is really built to provide acute care for children with one medical problem or few medical problems. For example, you go to hospital, you're admitted for a pneumonia, you get treated, you go home. That was sort of how the system, especially the inpatient system, worked in the old days, or when it was originally designed. Or to provide the system is built to provide chronic care for a single body system. And that care is delivered by the subspecialist, the pertinent subspecialist. So if you have chronic kidney disease, you have a nephrologist or a kidney doctor who's looking after the kidney. But really, we're looking at kids now that have multiple affected body systems. In our current system, intense communication really between care providers and caregivers was never incentivized or was not planned for. And to debate really the medical, the social, the educational priorities, because it's really more than just the medical priorities. And everyone has a different priority, including caregivers. And right now, with that said, really our care providers have little training, multidisciplinary support, and really time to co-manage or quarterback the emergence of these lifelong complex medical conditions, the multiple interacting treatments, the coordination of care for these families and these caregivers, and the treatment of what I call orphaned conditions. So complex nutrition, high muscle tone for kids with brain injuries, drooling, pain. These are things that don't really have a home. And a lot more complex care providers are providing that care. So really, to me, a new complex care model of care would be a place where a multidisciplinary team or care providers can really perform a variety of services to overcome these limitations. So treat complex problems within their purview, coordinate the huge number of appointments and tests. I have families that may be remote that come down from a remote northern community 5 times a month for a test, for an appointment. It's overwhelming, and really caregivers should not be responsible to organize the complicated scheduling of the children's appointments. These new models should coordinate the communication between care providers, so not just medical, but we have to realize it's medical, it's educational, it's social, it's home care. They're all providing care and families, they're all providing care. And really, we can't expect the families to be medical experts liaising and communicating with all these medical teams. So really, the care team needs the skills and the ability to moderate discussions between the care team, between the families, and balance all those priorities. Providing expertise to really co-manage complicated treatments and understand when treatments are interplaying with each other and recognizing when we have to prioritize one treatment over the other. And what I think is really important, and this is really providing a medical home or that continuity. So families really provide that continuity and guidance for families as they navigate transition, not just from traditional transitioning kids to the adult world, but really transitioning from inpatient to outpatient, between the school, between the home. These are all places kids get really their complex care delivered. And there needs to be that great communication and continuity so one person knows the family or one team knows the family. So that's really what the model that really needs to evolve, because these kids are just outgrowing the old system. And I hope if this becomes prioritized, then all across Canada, we can really beef up the care models, beef up the care providers so they can have the time, the resources to actually, attack these problems and help these families.
Great. Thank you so much. Nadine, do you want to speak to which one item on the list resonates the most with you?
I think I really echo Dr. Millar's thoughts around models of care. So I don't want to repeat too much. So I might pick 2. But certainly I think the models of care, I agree. I think it's particularly timely, and I was really excited to see that your focus on complex care, because I think with our escalating prevalence of complexity in our systems, for great reasons, we have more life-sustaining technologies. Children survive longer from prematurity. Children born with congenital anomalies are now surviving. But what this means is we have some very complex children in our systems, and we are seeing gaps and creating health disparities for these children and families. I think health and social disparities. And so I think I agree in terms of developing new models of care that will really address those health inequities and span sectors. So I think we are moving towards that. I think I agree. I see pockets of expertise in complex care. We have complex care programming for medically fragile children and acute care, spanning out to community supports. And I think what I'm excited about is over the next 5 years or so, we're going to see an amalgamation of these pockets of expertise in complex care. And I think that's where we're going to really start to see system level change. Because I think what we want to see is not that we are creating models that are absolutely having a positive impact on reducing disparities for families. They're improving efficiencies. They're keeping kids at home, keeping them out of hospital. I think we're having great success with some of the care coordination and the complex care programming, complex care, pain management, transitions. But I think what we want to see in the next while is this amalgamation of those programs to really achieve, I think, system level change and really remove the barriers that are creating these health inequities and change systems. That's going to take longer, but I really see some positive movement in that direction. So very excited about that. I was also very excited to see the genetic testing on the list. I think as we talk about, and Dr. Millar alluded to this precision health, and you focused on that last year, that sustainability for our health systems and to be able to focus on true preventive care for Canadians to have access to genetic screening, genetic testing, not waiting for children, adults to develop symptoms and develop disease, but to prevent. And I think we're really moving down that road, and I was really glad to see that one on the list as well. So thank you.
Thank you, Nadine. Laura, over to you. What one item from this list most touched you?
Thank you. And, definitely agree with my colleagues around the different care models. The one, though, that really stood out for me, and I'm going to kind of speak more from the personal experience rather than my professional hat right now, but was the genetic testing. And because for us as a family, genetic testing really changed our whole lives. So my son, it was kind of identified when he was about 3 months old that he had very low tone, couldn't hold his head up, was not tracking. I had an older son, who was 2.5 at the time. And as a parent, you start to know that something's not going as planned in terms of his development. And despite years of testing, we actually didn't get a diagnosis for Bryson until he was 10 years old. And he has quite significant physical and intellectual disabilities, really needs help for all activities of daily living, but is a super engaging young man. At the age of 10 years old, we actually did receive a diagnosis through whole exome sequencing. And that technology had not been available to us before. And it did take some advocating through his amazing geneticist. And it was discovered that he has a point mutation on the GRIN gene. And at that time, the diagnosis didn't give us much insight. We met with the genetic team. They said, yeah, if you look it up, you're not going to find much. And as we were driving home, we were looking it up, and I found literally like 2 or 3 papers on mice models, the GRIN gene and schizophrenia. So nothing at all related to what would be happening with my son. But what it did do was it began the building process for us of connecting with others. And initially, within a month, we were connected with 4 others from across the world, 2 in the US ourselves and 1 in the UK. And that was just 7 years ago. And then just this past weekend, my husband was in London, England for the UK branch of this kind of community of families, researchers, biotech, all working together for treatments and cures. And there were over 100 people just at that meeting. So it led us to not just having a diagnosis, a community, and now the research that's coming out of this, because families are all coming together, natural history studies are being done, and researchers are now interested in this. And even more so because they've been engaging with the kids and the families that it's impacting. And I would say that even like something that's even more significant for us is that it actually led us, because now we understand the neurology behind it through the research that's happened over the past few years, but led us to a diagnosis and treatment of paroxysmal sympathetic hyperactivity events, which are called neurostorms. And these episodes were previously treated as seizures, and the seizure medications were actually making it worse. I don't regret that decision to treat him for seizures because we didn't really know what was happening. But getting the right diagnosis, we're talking about precision medicine, his quality of life, our quality of life has changed dramatically from 20 episodes every day to days where he has none, and sometimes weeks where he has only 1 or 2. So I think it's important because I know there's a lot of dialogue right now about health system spending. Gene testing doesn't always immediately lead to a disease a disease that has a treatment or a cure, but we don't actually know the power of what can happen then down the road, both from a mental health perspective for patients, clients, kids, families. It really does create this partnership potential between families, researchers, people with the diseases. And, I think what we're going to learn is not just going to be helpful for our kids, but for those coming and then those with other diseases as well. So that's been kind of an exceptional change for our family, and really I'm so happy to see it highlighted there.
Thank you so much, Laura, and thank you for really putting a personal face on the list and on that particular item. And we're getting some great questions coming in through the chat. So let me just turn to one. Dr. Millar, maybe I'll ask you this one. What is the definition of complex care or a child with complex needs? In my area in Ontario, there are so many of us whose children have been denied admission to complex care programs, even though they are seen by many different specialists.
Yeah, that's a fantastic question. So at the moment, if you work in complex care, you sort of can feel, oh, this is a complex care child. That's not really helpful when it comes to clinic criteria for admission. That doesn't help with research when we're trying to create a population to learn from. Right now, there's a variety of definitions. The one that is generally accepted came out of actually Toronto was the lead on it in 2012, and it's really a framework. It's not like you can have a checklist. It's a framework. So the framework includes children with a chronic condition of some sort or a complex chronic condition of some sort. Children with functional limitations, usually presenting severe enough that they need technology to help overcome that, either to help them breathe, to help them feed, or even technology to help them move and get around in the world, wheelchairs and lifts and things like that. They need increased healthcare utilization, and that is a subjective term. Is it 5 admissions a year to hospital? Is it 5 ER presentations a month? We don't actually have an answer for that. And then lastly, family need, and that's probably the most subjective. What does that mean? So increased care coordination, financial pressures, dysfunction in the family because of the stress of trying to deliver such high needs care to these kids. So that's the general framework, but like you probably can recognize that could include a lot of kids. So there's a lot of work right now in trying to come up with a better, not a better definition, but a more precise definition. And there's a paper that I wrote that's coming out in Pediatrics that's attempting to add some objectivity to that really subjective framework. And with that paper, I worked with that same Toronto group. So there's going to be a lot of work to try and really come up with more precise definition. At this moment, clinics across the world, although they share basic features, they're all slightly different. And that's really because of slightly different priorities, slightly different needs or resources. So in Manitoba, we have a little more precise definition to really target the most complex. I don't have another word to say that, but the highest needs kids, just because resource-wise, that's where our resource levels, that's how we're targeting at the moment. Other places are more holistic and accept other children as well. I wish I had a better answer for you. I'm sorry, but that's where we are in the current state of the world. But there is work being done to try and more precisely identify these kids so we can really provide programming too that's specific for them.
So stay tuned, work in progress.
Yeah.
Okay. Nadine, the next question is for you, I believe. A few questions about the models of care, and are there any models that you're aware of, any innovative models that we can look at spreading and scaling across the country?
So I think right now, I think there's multiple models, and I think as we listen to Dr. Millar speak, I think the challenge in complex care is the diversity of this population and their needs. So I think any model we choose has to be flexible, and we need multiple approaches. So I think that's really important. There is not going to be one model for complex care. And I think what we're trying to do is look across the continuum of care, sort of to step back from the subspecialty and the programming and really look at the continuum of care for these children. And there are patterns and I think predictive pathways that we can develop for these children. And so we have sort of from the many complex care programs, as Dr. Millar alluded to, there's quite a diversity of models. Many complex care programs at acute care centers are focused on probably a very small number of medically fragile children. That would be the case in our hospital here at Alberta Children's Hospital. So really, again, the capacities to support complex children is still limited in our systems. And so needing to prioritize. And so I think some of the inpatient acute care programming is really on those medically fragile children, and really looking at how do we stabilize those children? How do we create integrated care plans, work really closely with home care providers, develop very sophisticated and successful discharge plans to really support those children living successfully in community. And so that's a focus of some of those inpatient acute care models. And then we see models that are more spanning outward. So where the hub is really the community. So children that are more medically stable, but not perhaps medically fragile. They don't have the long stays in inpatient units, but still are seeing 10, 12, 17 subspecialists. So very complex, but living successfully in community. And what we want to then look at is how do we create, ensure that they can stay home, keep them out of hospital, and really look at thriving. And I think it's the care coordination that people have spoke to. What's happening between visits for families? How do we support them to have, family functioning? How do we take away some of that burden? And I think care coordination is one of the ones we've had great success, really supporting families to alleviate that burden. And for us, it's not adding extra, it's creating health equity. Again, these families are experiencing significant disparities, financial challenges, the parental stress is often high, mental health challenges, siblings struggling, difficulty accessing, coordinating care. And so it's really trying to provide services that will contribute to health equity and alleviating that strain and burden for families so that they can focus on being parents and successful treatment. I think there are other programs, critically important models that we again need to start bringing together. Transition planning, critical for these children and families. I think transitions through the lifespan, not just child to adult, but definitely child to adult is a really difficult one, and we need to start early. So we need sort of transition navigator programs. And I think with our partners in allied health for pain management, rehab. So I think there are multiple models of care. And again, it's bringing those together to create really true integrated care planning that supports the needs of families and can be very flexible to meet these very diverse and customized needs of these children. So
thanks so much. Laura, I wonder if you want to speak to a care model that you're currently involved with.
Yeah, for sure. So, and just to reflect back on what Nadine was saying around the transitions at different life stages as well as into adulthood, I think it's such an important reminder that transitions happen at different times and they don't always follow the trajectory of school or age or sometimes their development, but sometimes not, right? So, but along with that, actually, if we could be thinking about caregiver transitions at the same time. So caregivers actually transitioned through the lifespan. When my son was very little, it was really a grief journey for us at the beginning, an unknown. It was a fear. Now that my son is 17, it's more like, how am I going to keep my back from, being healthy and so that I can keep lifting him? And what's the unknown of transitioning to adult care, and then also having respite and other supports. So one of the models of care that we're receiving support from right now is called Lifespan. And Lifespan is a program run in partnership between Hull and Bloorview Kids Rehab Hospital and the Toronto Rehab Institute, both in Toronto. And essentially, it's a partnership to support youth from transitioning between Hull and Bloorview and Toronto Rehab, but also the focus is on the transition. So as individuals with disabilities then move into the adult sector, there's a medical component. So there's the nurse navigator, there is the health and social services component. So ODSP, so Ontario Disability Supports, how do we apply for respite funding? It's all going to change all in this kind of year-and-a-half timeline. So how do we apply for those programs? I'm a clinical social worker. At the same time, I don't know about guardianship and POA for my son. And actually those can look very different depending on his place and where he's going and what our plans are with him. And so there's actually a pro bono lawyer connected to his to that program that we can now connect with around that as well. So what I like about the model, it's not just medical, it's social. They talk about school, they talk about day programs, and it's a navigation. And I know every time I meet with them, there's something I've forgotten to do, and they just keep gently keeping us on track. And it starts at 16 and goes all the way up to 24. And now they're expanding to try to look beyond that. That navigator, it's the one thing, if I could just magically say we need in the health system, a point of navigation, because it is so complex and it's either all up in your brain or it's in a binder or it's maybe on 18 different portals. And that's where the interoperability comes in and how everything speaks to each other. But that navigation is a real core component. And it really just improves everything, right? So how the relationships, how patients, clients, families are doing, and then ultimately then quality of life for those who are impacted.
Thanks for that. Yeah, I want to read a question here that really just more so to sort of emphasize, the angst of what you just shared with us from one of the members of the audience. Regarding mental health support for caregivers, as both a healthcare provider and a parent with a disabled child, one of the elements that affects my mental health the most is future planning. What supports will my child have access to when I can no longer navigate and advocate for her care? So many programs and supports are underfunded or supported once the child reaches the age of 18, or not supported once the child reaches the age of 18. How can we reconcile the care models or support structures and funding provided for programs that continue to use traditional definitions of children and adult when support needs do not change once children turn 18?
Yeah, very well said.
Yeah, very powerful question. Why don't maybe I turn to the issue of interoperability? So different digital health systems should ideally be able to share and exchange information really for all of us. But we know that this isn't often the case, and there are challenges that arise when these systems don't communicate with each other. Dr. Millar, I'm wondering if you can maybe speak to this from your perspective, some of the challenges that families and providers face when the digital health systems don't communicate.
Yeah, thank you for that. I'm actually going to be really interested what Laura has to say about this too, because she experiences the frustration of meeting care providers that don't know your child. So really, this is an issue that really is important for all patients, to be honest with you. But because our kids with medical complexity have such a higher number of contacts with the healthcare system, contact with social system, I think it's felt particularly acutely by them, but really it could help all patients. I always give the example, you have a family presenting to the ER. They have complex needs. They have complex interplaying treatment strategies, whether it's medical devices or medications. And you're always finding that balance, because don't forget, a lot of these kids have multiple conditions that are sort of co-mingling with each other. And then you treat one, it puts the other body system out of whack. And really our jobs as the care providers is to find that balance to really, minimize the fragility and find the balance so kids can go on and live these like as normal lives as possible. So then you present to the ER and maybe you have something simple like a viral cold, but that is the littlest sort of non-noxious. Usually it's totally fine for most kids, but it just throws everything out of whack. And then you're in the ER, it's a time pressured space. Parents now have the burden to try and explain what happened in the past 5, 6, 7 years, all the treatments that have been tried, all the conditions. Some parents don't have the same medical literacy as others. And then the ER doc has to make a decision, and they don't even know the patient or the treatments or everything that's been tried in the past. That's a pretty frequent occurrence, I must say. So really a communication system like an EMR, I mean, we have some centers with no EMR. We have some centers with their own EMR, regions with their own EMR. There's a province that has a provincial-wide EMR. So it's in a different state all across Canada. But really, if they could communicate with each other within that system, you could have access to the entire medical history. But complex care programs tend to make complex care summaries, which summarizes care plans, emergency plans, summarizes the past history, what's been tried in the past. And you could just have access to that. As an ER doc, I would just be ecstatic if I could actually have that kind of information. So really, they need to be shared between healthcare settings, inpatient, outpatient, etc. But also it needs to have a way to be shared between the other aspects of life, schools, home care. Parents need a portal so they can access it. And it really needs to be shared not just in the healthcare system and within different social systems, but across provinces, a national EMR. I know that's a big ask, but could you imagine if you are on a vacation, you're presenting to BC from Manitoba, or you're switching provinces? That would be really helpful. That's a huge ask. I'm not going to pretend that that can be done tomorrow. And in Manitoba, we have a lot of remote Indigenous communities who their healthcare is delivered by nursing stations. That's a federal program. Trying to communicate between a federal program, a provincial program, there's so much lost there. So if those things can be worked out, we can all have access to, everyone's care, and the parents can understand what the care is. They can see their upcoming appointments if there's a parent portal. It would be phenomenal. I sort of see interoperability also. You mentioned communication systems, but I wonder if it can also be thought of in the term of a shared base standards of care, so that the base standards of care in one place can be expected wherever you move. So the communication in the EMR is great, but also if you move jurisdictions, you have a base level of care that you now know. You will get this technology, this medication, whatever, wherever you go. That's another very big ask, especially in a system where it's provincial run healthcare. But yeah, that's what I noticed. And that's, I think, would be a critical win if we had more widespread EMR that could be more easily talk to each other. I'm sure Laura has something to say about that.
Yeah, Laura, go ahead.
Yeah, I hope you don't mind. And maybe I'll also just bring in my work hat. So at UHN, part of our portfolio in patient experience is with the My UHN patient portal. And so all of the test results, notes, everything is going directly to patients in real time. And I find that that is an enabler right off the bat, because if a patient is going to different settings, they can actually just pull up themselves and show what they, this whole medical record. At the same time, it's still just one site. So, and the number one ask from our patients when they call into our support line is one login, one provincial or beyond health record. And then how do we integrate without creating all these other apps and applications that do the telemonitoring, right? So heart rate, biometrics. How can we start to integrate some of these systems as well into the shared care? And then having that also then get integrated into the health record. The health human resources, I know it's such a challenge right now in healthcare, but roles are changing too. And I think we have to be really thinking through what are the new roles we're going to need in healthcare. We talk about navigation. We're going to be using biometrics and telemonitoring. We're going to need new health professions to be able to do that. But really kind of going to this interoperability, how do these systems speak to each other? And then carrying that down the road is the digital health literacy piece. So if it is going to be a consumer tool, client, patient, family, making sure we're providing support around digital health literacy. And so again, our team is really focused on, if you are going to provide this access, then we can't just accept people to use it, adopt it, and know how to use it, have access to Wi-Fi. And actually in our kind of roundtable or the James Lind process, I know families were also in that talking about like, yeah, I don't necessarily want to be more at the hospital, but please, like, I'm really, at those early days, I was afraid to take this equipment home. So maybe I'd prefer to have it taught to me there, and then I can bring it home. But then how does this information continue to flow into the hospital so that somebody is monitoring it, so that you're not left, right? Thinking, okay, now I'm really on my own. So I think technology, there's so many new opportunities on the horizon. just think we have to make sure that we're clinician and patient, family, they're coming together to learn how to use those as well.
That's a great example. Thank you. I want to go back to a theme that was in some of our earlier questions around caring for the caregiver. So family caregivers of children and youth with medical complexity provide a substantial amount of care. As we know, this work is often unpaid and underappreciated and could take a toll on the caregiver's mental health. Nadine, maybe I'll ask this question of you. How important is it for family caregivers to be supported and cared for, and what could this look like?
I think it's critically important that when we think of care of complex children, it's a family process. We're caring for families. So I think in our models of care and our programming, we're supporting caregivers. I mean, the way we're going to get really good outcomes and keep children in community is to support the family, to care for that child. And so I think models need to be designed absolutely to support the family, to work with caregivers and parents to develop what are their priorities. I think really understanding the family circumstance and meeting families where they're at. What are their priorities currently? How much management can they take on? How much do they not want to take on or don't have the capacity? So I think being very flexible, very mindful of parents' stress, the amount of work that they're doing, as Laura said, understanding, are they comfortable with the technology, managing that technology at home? I think families are also having to, even in-home supports, they're now becoming managing those staff in their home. They're hiring, trying to hire. They're experiencing staff turnover in their home. How do they have consistency? And so that can be very challenging for families to try to keep and acquire adequate in-home supports. Respite is very limited, particularly for very complex children. I think respite and out-of-home placements, even if they're temporary, to give families a little time to breathe if they need that and if they need to manage their own mental health. So I think respite is important. I think we have really significant gaps in our services for children who have very severe challenging behaviors. They're often excluded from supports, from respite, from programming, and then the family is at home trying to manage. And we see these kids coming into the emerge and these families just can no longer cope. And so I absolutely think when we're developing any programming, that there's a strong emphasis not only on the medical management, but on supporting parents and families to be functioning, to thrive, and to take away some of that burden on them for this, as we've been talking about, that coordination of care. And I really agree with everyone when we're saying across services. The navigators, the care coordinators, it's really the one role in healthcare that has a whole picture of what's going on for this family, what's happening for them with housing or financial challenges, what's happening in the schools. Do they have adequate school supports, or in the social services system? Are they connected? Do they have language and cultural barriers that we need to address and think about? Why is it they're having trouble perhaps following through with some of these recommendations? And maybe it's because we just gave them 20 different recommendations this past week. So I think those roles, really looking at the whole picture for a family, is just really critically important.
Thank you. Dr. Millar, I'm going to ask you this question around evolving practice. So the field of complex care is evolving, bringing with it new roles and responsibilities for healthcare professionals. You spoke a little bit about this in your opening comments, but could you maybe talk about how have you experienced changes over time in the practice of pediatric complex care, and what do you see as some of the biggest challenges to that evolving practice?
Yeah. So I currently practice in a consultant complex care clinic. So our kids often have their original primary care provider, whether it's a pediatrician, sometimes a family doctor. And then we sort of provide a consultant role or sort of help co-manage these kids. In that role, I have had to adapt a lot from what would be a base pediatric education. So we've had to learn how to treat those sort of orphan conditions I mentioned before. There's some regions that won't have a subspecialist like a physiatrist treating high tone. So we've learned to start treating high tone. Who treats pain? Well, a lot more services, a lot more regions of complex care teams treating pain. Excuse me. Nutrition, complex nutrition. Maybe kids have feeding tubes. So those are things that the complex care group is now really starting to push forward and having to understand and stay up to date on and learn those things. The other thing is care coordination navigation. I can tell you, I was in med school for many, many years and residency for many years, and I never learned about this. I didn't know how to do it. There are allied health professionals that can help, but really to help families navigate, you have to stay up to date on an ever-changing system where you'll have a program one day, 2 years later, it's gone. And then you have to know what the new program is. You got to know what the adult program offers. Like those are things parents need from you, and you have to be up to date to provide them. So that takes a lot of time, a lot of extra training. And I find the biggest thing is a lot of my job is co-managing multiple subspecialists' care. So they're recommending a kidney, not to harp on nephrologists is the second example, but they're recommending a kidney treatment. The respirologists are recommending this treatment. The endocrinologist, they're all recommending different treatments. Everyone has their own priority because of their subspecialty. Parents have their own priorities. How they participate in the world creates new priorities that you have to understand so much of the complexity that's spread over subspecialists so that you can understand how can you bring it out all together into one holistic plan. So you're not going to be an expert in, a complex trach and vent child, tracheostomy and ventilated child, but you have to know enough so that you can problem solve when those sort of frontline issues come about, and also understand enough so you can bring a plan together into one holistic plan. Yeah. Yeah.
Thank you for painting that picture. So we have about 8 minutes left. I just want to ask each of our panelists, if there was one message you could leave behind for the audience as a key takeaway, what would it be? And Nadine, I'm going to start with you.
For me, it's really, I'm hoping that there will be a day where we don't need care coordinators and navigators anymore, where we've really tackled the bigger system issues, that we have true cross-ministerial collaboration where child-serving ministries are working together, they have joint funding and approaches, and we have true integrated systems for these children and to benefit all children. So that is my hope, that we don't need some of these focus. And I really, the emphasis on not just managing children's health, but on thriving for families and children in their community, and really focused all of our programming on quality of life and thriving for families. So,
thank you. Dr. Millar?
I think for me, it's just to get home that these kids are here. Their prevalence was increasing, may still be increasing. I don't want to speak too far into that yet. But their impact is increasing. So they're here, and the system has to evolve to the new reality. So we need to understand them and we need to provide for them because, their impact is huge on families, but huge on the healthcare system, huge on the social system. And if we can manage the impact, it's good for the kids, it's good for the families, it's good for everyone. And I just want to sort of similar point is we in the healthcare system have become very good at keeping kids alive. And I think we need to start thinking, how can we get these kids to optimally function and participate so they can actually live that life now?
So beyond alive, thrive. Yeah. Laura.
Yeah, thank you. I think for me, it's more of a reflection on this process and the final report. And what I do want to say about it is that I just really appreciated that the focus was not just on technology, on drugs, on innovations. Like there's a lot of cool stuff that's now emerging and happening. And, people are coming out with things that are going to drastically change our lives. But there's also an element to this report that is strongly on the side of like that human side of medical complexity. And, I think our challenge going forward is going to be in continuing to find our core rooted in that compassion and relationships that integrate holistically. So what my colleagues here were saying, like, it's not just about an organ system, but the person and the holistic part of that person. And how do we, use the tools and technologies to make life better? And so this whole person thinking, I think, actually really came out for me in this report that could have been just a list. And it's really, and Suda, like you mentioned, it's not a list top 5, like 1 to 5 in order. If you take the different components, you can almost see how they build around someone's life now and in the future. So yeah, so thank you for, the opportunity to participate. It really has been a really interesting and exceptional experience to be part of.
Okay, thank you so much. And that's it for time. I want to thank our audience for attending the launch of the 2024 watch list. We hope that you found it informative. A huge thank you to our amazing panelists for sharing your insights and your expertise. We heard throughout the process of developing this year's list that we heard from healthcare providers, researchers, policymakers, industry, and caregivers. As you said, Laura, really the importance of access to high quality care for children and youth with medical complexity. And our hope is that this work will really help the health system prepare for rapid advances in technology, but ultimately improving access to better care. And we encourage you to read this report and share it liberally with your networks. A huge thank you to the CADTH team for all of their work in pulling this report together and in preparing for today's webinar. Thank you again for joining us. Everybody, please have a great day, have a great week, and thank you again so much for your attention today. Take care.